trying to squeeze in a good discussion. Thanks everyone for joining us this morning. For those who don't know, I'm Aveek Bhattacharya. I am Director of the Social Market Foundation. Thank you for joining us for what promises to be a very interesting discussion on a very important topic. We know that there are disparities both between ethnic minorities and the majority white population, and also within ethnic minorities, both in terms of the sorts of mental health outcomes that we have and differences in treatment as well. So we're really pleased to be partnering with Policy at Manchester to share some of Professor Don Edge's research and interventions for trying to address these ethnic disparities, and then open that up to a wider discussion about what policy and the sector can do to address these challenges. So I'm just going to do a bit of housekeeping. We'll turn to each of the panel for a 5-minute kind of introduction to the topic, and then open up to Q&A. So do be thinking of your sharpest and most insightful questions. Just so you're aware, we are recording the event, which will be put up online later. So be aware of that when you're making your interventions that will live on the internet forever. So use appropriate discretion. For those of you who tweet, our handle is at SMF Think Tank. University of Policy of Manchester's is UOM Policy, and the hashtag is hashtag LAB23. If there is a fire, follow the green guy. He looks like he knows what he's doing.
Not literally a green guy.
But yes, pleased to get us started. And first I'm going to hand over to Professor Don Edge, who is Professor of Mental Health and Inclusivity at the University of Manchester.
Thank you. Good morning, everyone. It's a pleasure to be here, and I'm going to kick off by just talking a little bit about health inequalities specific to mental health a little bit, and then telling you something about my work. And as Aveek said, it's really important for us to say and to acknowledge that inequalities, or disparities, sometimes they're called, occur to people across different ethnic groups, across age span. It's a major issue, and that's not just in terms of outcomes, but people's access to care and their experiences whilst in care, as well as their outcomes. And what tends to happen is that those disparities are amplified at what we call the intersections of kind of key protected characteristics, of things like gender and age and socioeconomic status, which is not a protected characteristic, but it's one of those things that really helps to define your access to care and your experience and outcome. So there is a real close correlation between health and wealth. So basically, generally speaking, the inverse care law is that those who require the most care are least likely to get it, but also the wealthier you are, the better your access to health care. And some people will be familiar with Sir Michael Marmot's phrase, the social determinants of health. I find that phrase a bit problematic, because it kind of suggests that this is a fixed entity, and it isn't. If you have the will, you can change people's life chances no matter where they start. But I'm sure that's something we'll pick up on later on. But it is important to acknowledge, I think, which is what Marmot was doing, that if you start your life off in poverty, you're more likely to end in poverty, and along the journey you're more likely to have poorer health. But I'm focusing on mental health, and particularly around ethnicity, and just to, because we don't have long, just to give some kind of headlines, so and to pick up on that life course aspect of this. So, in terms of children, well, let me just go back a little bit. So even before you're born, so the perinatal health of black women. Some of you will be familiar with the campaign 5 Times More, because as happened with quite a lot of things around disparities during COVID, people had the time to begin to kind of really look at things around inequalities after George Floyd and those pictures on the TV from COVID. And one of the things that came out of that was the recognition that if you're a black woman in Britain, you're 5 times more likely to die during pregnancy and childbirth than if you're a white woman. It's come down a little bit, it's 4.2 now, so we're moving in the right direction. if you make it through the baby, and you make it through, you're more likely to survive into infancy if you have a black doctor than a white doctor. Okay. So bringing it on to mental health, children who are diagnosed with autism are 60% more likely to be from socially deprived backgrounds. And those who don't have English as their first language are also at increased risk of being diagnosed. So 36% less likely to have English as a first language. And if you're black or multiracial, you account for about 5% of a child and adolescent mental health service population, so that CAMS, but 36% of those are held at the highest level of security and detention. And at the other end of the scale, for older people, and this is to highlight the point about why it's so important not to kind of clump people together under the BAME. We don't do that very much anymore, but kind of it's really important to delve into the differences within groups as well as between groups. Because for older people, if you're of Black, African or Caribbean, you've got a 22% higher incidence of dementia than the white British population. But for South Asians, it's 17% lower. So one of the things that we tend to do is to focus on what the problems are, rather than looking at why some outcomes for some people are much better and trying to find out what we can do to amplify the good stuff. We do tend to, a lot of times, to focus on the other thing, which is a feature, I think, of although we have a National Health Service, our focus is really on illness. We don't do a great deal around health. So my work is primarily focused on inequalities in a lot of things. So I do some research around offender health, but today I'm just going to talk about some research that we're doing into psychosis care. So the backdrop of that is if you're black or mixed heritage of African or Caribbean descent, your risk of being diagnosed with schizophrenia is about 7 times greater than a white British person. It's not if you're in Africa, it's not if you're in the Caribbean, it's much more like the global average. And alongside that, much more coercive care, so the pathway into care is more negative, about 4 times as likely to be sectioned under the Mental Health Act. And once in services, you're more likely to be held in seclusion, experience control and restraint, high levels of medications. And about 2.5 times, your inpatient stay is about 2.5 times longer than if you're a white British person. And when you are discharged, you're much more likely to be discharged on what are called community treatment orders, which means that you're out, but you're not really out, because you can be recalled at any point. One of the evidence-based care interventions with a really strong evidence base of being both cost and clinically effective is family work or family intervention, family therapy. But minority families are much less likely to receive family therapy, and actually family therapy is really poorly implemented in the NHS, despite being recommended by NICE. So we need to find out why that is. And we actually haven't done that much research to find out what the uptake would be amongst minoritized communities and what the outcomes would be. So that's the work that I'm doing, which Lade is also involved. And what we did is we basically took an evidence-based model of family intervention and worked with people with lived experiences, service users, as carers, as health professionals, as well as family members, and looked at what we needed to do to make it more accessible and more culturally informed. Really importantly, one of the things that people told us was that it wasn't so much that the therapy needed to change, it was the therapists. And we need to do the work around making therapists much more aware of the lived experience, the life experience of black people, that brings them into mental health services, and how some of the discrimination and racism that they face in everyday life outside the NHS is then replicated inside the NHS. So out of that, we've got this 10 sessions of culturally adapted family intervention, and we're currently evaluating that in services across England. And just to make one final point about how easily inequalities can be reinscribed in a system that looks, on the surface, very fair. So NICE recommend family intervention for all families who are for all service users in regular contact with their families. So I'll just give you a moment to think about what that might mean. If you're a care leaver, or if you've fled conflict and you've arrived here on your own as an 18-year-old or 14-year-old, or even if you're here as an international students. So the whole range of reasons why people don't have regular contact with their families, but they would automatically not fall under the umbrella of being receiving nice recommended treatment. So I was also thinking about what messages for policymakers, and I think one of these is evident. We need to take a life course approach to improving mental health and well-being, and certainly tackling inequalities. We need to really use the power that commissioning has, and policymakers need to set the tone for that, to actually not just procure services, but to commission services that meet the needs of the population. And then the other thing is to really think about having a much more solutions-focused approach. So as I mentioned, I think the NHS is very focused on illness, and we really ought to be looking at what are the community assets, what are the things that people who are doing well, and certainly not ending up in our services, what's keeping them reasonably well, what's enabling them to function in even difficult circumstances, and what can we do to amplify that. And really, again, in terms of services, is to work with people who are experts by experience. So the mother who's been trying for decades to get care for her child is self-harming, or somebody who's lived through mental health services. So let's work with those people as well as the people who are delivering the care. And I think finally, there's the rise of technology and digital health, and I think that's great. But if you think about the people who are least likely to be online, to have either the literacy or the health literacy or the digital literacy to be able to maximise the impact or the potential benefits of digital health. And if we're not careful, we're just further reinforcing inequalities that we're talking about. So I'll stop there and pick up the conversation.
Thanks. So much packed in there, and a lot to pick up. Thanks so much, Dawn. Next, I'm going to hand over to Jasmine Ali, who is Deputy Leader and Cabinet Member for Education, Children and Refugees at Southwark.
Thank you. Thank you very much. And I just wanted to say thank you very much to the Social Market Foundation at Manchester for putting this timely seminar on, and I'm very pleased to contribute. I just wanted to say that I brought my fellow Cabinet Member with me, Councillor Evelyn Akoto, and I look after the mental health for children and young people, and Evelyn's looking after the adults, so hopefully we'll hear from her today as well. So look, I just wanted to say that I'm here from Southwark Council, and Southwark is very densely populated, diverse in a London borough, and we make up a patchwork of communities, and they're very different from one another, because you've got, on the one hand you've got Dulwich, you've got the South Bank, you've got Tate in Liverpool, we've got Tate, and we've also got the area that I live in. I live in Peckham, and it's very Evelyn lives in Old Kent Road ward, and so the density of the population are and the outcomes, the health outcomes, are massively different. So really, a couple of stats really. So we've got about 300,000 people, so it's like a big London borough, and it's very young. So what is interesting is that we have a wide range of ethnic and social backgrounds, and the youth, we're a younger borough, but we're also younger nationally. So the average age is 30, and it's more than 2 years younger than London, and almost 7 years younger than the rest of England. Around 51% of people living in Southwark have a white ethnic background, compared to 81% nationally. The largest ethnic group other than white is Black, British, Caribbean or African, accounting for 1/4, 25% of Southwark residents, comparing to only 14% of residents across London and 4% nationally. So more, I think it says here more than 80, but we were talking about the language because it felt low. Even thinks more 120, but that's the difference between the council and the health stats. But we've got over 40 distinct religions identified as Southwark residents. So what does that all mean then? Basically, if you look at the stats that we've heard from the professor, basically you're more likely to have a mental health issue if you are Black, Asian or a member of another ethnic minority in this country. You are basically 4 times more likely to die as a Black woman giving birth, twice as likely as an Asian woman, as we've just heard. And during the pandemic, at the height of the pandemic, 4 times more likely to die at the height of the pandemic. And so what does that mean in Southwark? It meant that we were seeing and living it. I look after social services, And, you know, we lost, you know, basically, during the first lockdown, we lost 4 women the same age. I'm a bit older than Evelyn, but the same age as me and Evelyn, you know, like leading lights in social care. And they, you know, that basically we were seeing it and feeling it. So what the point I'm trying to make now is that what we do in Southwark is important, because, you know, if we can't get it right there, you know, what hope have we got? So I did want to say a couple of things. I wanted to say the local data on inequalities shows that 72% of households comprised of solely black residents experience disadvantage. 28% of black adults experience food insecurity, compared with 8% for white adults. 11% of black residents have 3 or more long-term health conditions, compared with 7% of white residents. So, you know, you can see it. So in 2018, I wanted to give a bit of hope, really, you know, as I'm concluding. But in 2018, when Evelyn and I joined the cabinet, I inherited CAMS. And it was quite an interesting issue, because we have, I don't know if there's anyone from Lambeth in here, but yeah. So in Southwark, we said that we were not going to, you know, in our manifesto, that we were going to revolutionise CAMS. And there was this massive meeting with like angry residents from Lambeth, angry residents from Southwark, and they had like these placards with hands off CAMS. And I, you know, basically, I was a new cabinet member, and I was thinking, what are they talking about? We said that we were going to invest in cabs, not cut it, but obviously I think someone in Lambeth said that they might cut it. So then I looked at this review. I inherited the portfolio, but a review, and in the review it said, you know, the target for supporting children with mental health needs was, you know, for the NHS target in 2018, when we literally had an epidemic, you know, 1 in 4 children will have mental health needs nationally. So it said 35%, that was the target. The NHS would support 35% of children with and young people with mental health needs. So, I mean, I'm a new cabinet member. I got up and I said, well, this is nonsense. And in Southwark, we will be supporting 100% of children and young people with mental health needs, just like any self-respecting parent. And then, obviously, the cabinet were a bit angry. They said, why didn't you say 60% or 50%? And I said, look, you know, no one's going to kill us if we don't get to 100. But the point is, where's the aspiration? And do you know what happened? Well, I fell foul of it as well, because by the time we got to Council Assembly, I just read that the government were doing 100%, but in their 10-year NHS plan. So I said, we'll do it by 2020. Anyway, so basically what happened? You know, local government is like a machine, you know, and obviously I could talk amongst friends, I wouldn't say it outside of the conference, but sometimes it takes a long time to do things. But do you know, before we'd even spent a penny, it was already people were on their A game. We had given people permission to do the very best for people with mental health needs. And we invested $2 million into schools for mental health prevention. And we opened up a mental health drop-in. Now, I'm going to get to something relevant now. We opened that drop-in, and it was more by accident than design, because you talk to children and young people what they want. They said they wanted something between a Starbucks and an airport lounge. That's what they were saying. I was thinking, that sounds awful. They wanted to call it the Nest, and I was getting more embarrassed about this concept. But actually, they ended up opening it up in my ward, and I was thinking, wow, that was more accident than design. And do you know what? They took down this, you know, like a pawn shop, and then they renovated it. And it's really, any of you want to come and see it, I'll show you what it's like. And it's basically, what happened is during lockdown, we basically were ready to open it. So we opened it online, and it was just phenomenal. And basically, my colleagues in the NHS had said to me, if you don't hardwire it with what we're doing, because they didn't like the idea. They said, if you don't hardwire it, it's never going to work. But obviously, it advertised itself. And, you know, people kept coming. And I'm getting to the point now, because anyone that knows Southwark, what happened was, we had all the practitioners there, more accident than design, were black and Asian. And, you know, 97% of the clientele were all black and Asian. And that is in complete contrast even. Up on the hill, we have South London, and Maudsley. And then there's a new Pairs, there's like this amazing facility that's going to open, Pairs, where you have a hospital, and sorry, it is a hospital, but when you have a school in there for children with mental health needs and everything, but they have majority white clientele, and so it shows you what you can do in the community. So that is, a very stark example. The other thing, very quickly, is that we did Southwark Stands Together, and Evelyn and I and another counsellor, we did this mass listening exercise. We saw that, what happened to George Floyd, that racist murder in the US, what happened in Southwark is that in Peckham, it was like, the movement was happening on our streets. All the black young people were saying, that we had to do something about it. So we had a big listening exercise, and we launched Southwark Stands Together, and residents told us they wanted access to service, better outcomes, culturally appropriate services. They wanted therapy, not sections. That's what they said. And residents told us that we needed to close the health gap. So on Labour policy then, Labour policy wants parity, with mental health services and physical health services. And they say, don't know, there's a whole thing, if you had a broken arm, you wouldn't have to wait. But basically, that's a moot point right now. Inequalities of access, experience and outcome, we need to tackle that and, look at the difference experience. So today, Labour is setting out a plan for a decade of national renewal. And that renewal must include, and will include, something supporting the mental health of, our people, young people, old people, black, Asian and white, a renewal that all can enjoy, and a renewal in which no one is left behind, and that's the minimum that we want, isn't it?
Fantastic. Thanks so much, Jasmine. Next I'm going to introduce Dr. Lade Smith, who is President of the Royal College of Psychiatrists, for her thoughts.
So, first and foremost, a declaration of interest. I actually am Clinical Director of Mental Services at the South London and Maudsley NHS Foundation. Jasmine. Anyway, so the first thing I need to tell you is this. It's very, very clear now. Inequality is bad for mental health. Simple. And the other thing I need to tell you is that we know what causes mental health problems, actually. We know that genetics are important, but frankly, just because you've got a genetic predisposition, it does not mean that you're going to develop the mental health problem that other people might have done in your family. Because we know that perinatal factors are important. What happens to you when you are in the womb? So the nutrition that you are given, whether you are born small for dates, whether you are born prematurely. If you're born prematurely, you have a massively increased risk of developing illnesses like schizophrenia 20 years later when you are in your late teens, early 20s. We know that what happens to you when you are young and how you are treated is really important. Just as we know that bereavement as an adult and trauma as an adult can really affect your mental health, it massively affects your mental health if you are a child. So we know that early life experiences that are negative, being emotionally, physically, sexually abused, and of course if you're physically or sexually abused, you're also emotionally abused. Those things will increase the risk of you developing a mental illness later on, full stop. We also know that if you are someone who unfortunately has been brought up in a very anxious environment or an anxiety-provoking environment because you're witnessing domestic violence constantly and you're anxious, and you happen to also live in an area where there's a guy down the street who'll say, I see you coming home from school every day when you're 11 or 12. You're always looking a little bit worried. You're always a bit worried about the bullies at school and things like that. Have a little bit of this spliff. This will make you feel better. And you know what? It will, because things like cannabis, amphetamines can really help you feel a little better when you're younger. And not just when you're younger, when you're older too, as many of you know. And in that short time, unfortunately, your brain is growing. Your brain doesn't stop growing until you're in your early 20s, especially if you're a bloke, it might be 25. If you are growing your brain in cannabis soup, it does have an impact on you, actually. If you start using cannabis regularly, that's a spliff a week, from the age of mid-teens, 15 or so, your risk of developing a psychotic disorder by the time you're 25 is 5 times higher than normal. So, we also know that, adverse childhood experiences are massively, they drive terrible illness, not just mental illness, actually, physical illness as well. if you have 4 adverse childhood experiences witnessing domestic violence, being neglected or abandoned by your parents, being abused, you will be 2 times more likely to die from cancer, 2 times more likely to die from heart disease, have a 20-year shorter life expectancy. And you will be someone who's much more likely to have substance use and alcohol problems, more likely to be in prison, and so on. So we know what causes mental illness. Now what's interesting is this, that as psychiatrists, we're very aware of this. I mean, we've got an early years, we know that what happens to you in your early years is important, and we know it's very important because 75% of mental health problems arise before the age of 24. Why is that important? It's important because unlike physical health problems are diseases of middle age and older adults. You don't start getting high blood pressure until you're in your 50s. Your osteoporosis sets in when you're postmenopausal. And these are disorders that kill people. But by the time you've got your high blood pressure and your chronic obstructive airways disease, you've already reached your peak productivity. You've already bought your house if you're lucky, or you've already got your family, you've had your relationships, you've had your kids. But if you develop your problem when you are in your teens or early 20s, then unfortunately you're not likely to achieve your potential in the same way. You might be fine, but you might not do as well as you would have done otherwise. Yeah. You're not going to have the best relationships. You're probably not going to be able to finish university. You're more likely to drop out of school, which is what happens with my patients. And unfortunately, you won't reach peak productivity. So it's not just important for the individual and their families. Frankly, it's also important for the productivity and the prosperity of the country. Next week we are bringing out an early years report. The Royal Society College of Psychiatrists. We spent a long time developing this report, working with a number of different organisations, including organisations like parent-infant interaction groups and things like that. And what we know is this, that if you intervene in the first few years of a child's life between 0 and 5, then you can actually divert children from becoming the people who develop mental health problems. You can effectively treat them, in many cases essentially cure them, stop people from becoming unwell. Okay, so he's like, well, yeah, what about ethnic inequalities? Well, the problem is this, that all those factors that I described are much more prevalent in people from minoritized ethnic backgrounds in this country. It's as simple as that. So we know that all those inequalities, all the things I've described are much more prevalent. And a really important one is this, poverty. Now, if you're in the top 10% of the population in terms of wealth, it doesn't mean you're not going to have a mental health problem. In fact, 6% of people who are in the top 10% of wealth income actually have, mental illness. So it doesn't protect you, but it does help. Because if you are in the bottom 10%, 16 to 18% of people will have a mental health problem. And they're the ones that we know about. So you are more than twice as likely, 2.5 times more likely to have a mental health problem just because you are poor. Just because you are poor. If you live in a deprived area, you are much more likely to have a mental health problem, full stop. And actually, being poor and being deprived, what it means, it's not the being poor, it's not the having no money, it's what it's related to. It means you're more likely to live in a tower block that has lead in the paint, because people have painted over it again and again and again because they haven't been able to afford to decorate it properly. Why is that important? Lead is associated with mental health problems, associated with learning disability. You'll be bringing your kids up in a toxic environment. You're more likely to live next to an A road with pollution being poured into the atmosphere. You're more likely to live in an area with a poor school, where you're more likely to live in an area where there are just too many people too many people in the classroom, so the teacher can't attend to your very individual needs, and so on and so forth. The other problem is this, discrimination. The evidence is pretty clear now, actually, that discrimination is associated with development of mental health problems. And that's all types of discrimination, actually. Remember, there are different types. There's the individual stuff, personally mediated, when someone's nasty to you and says horrible things. That's what we all know about. Then there's the institutional stuff, but really importantly, there's the structural stuff. It's very hidden. kind of codified into our existence and we don't notice it. It's just that everyone knows that certain people just aren't quite so good as other people and so on and so forth. And the problem with ethnic background in this country, you have all those factors against you, and that increases the risk of you developing a mental health problem later on. The other thing is this: if you are from a poor background, we did a very nice study recently. I say that myself, even though I was involved in making my own study, but it was a good study. It got into a very, very good journal, showing that if you were from a lower socioeconomic background, then not only was it, as Dawn has said, it was harder for you to get into services, access services, but once you were there, you just didn't do so well in services. Basically, the services don't cater to your needs, and that's no surprise because the services are developed, the research and everything else is developed among people who are the majority group, and most research is done on, college students in America, often white males, and it means that they don't, and then it's extrapolated to everybody else. Anyway, I know I've been going on for a little bit, but essentially, the answer is quite simple, actually, and we've known the answer for many, many years. Those of you who are sitting, the fact you're here means that you care, and that's fantastic. But the reality is that even though there's a moral, there's an ethical, there's a clinical imperative to do something, it's not enough. And I say that having done this work for 30 years. It's not enough, because if it was enough, we're all nice, we all care, we would have changed it by now. The reality is that when it comes to mental illness especially, there isn't parity of esteem, actually, with physical health problems. It's always, oh, well, it's out there. It's okay. I mean, Jasmine has described a fantastic service, but I need to say something to you. Actually, that service will be great for people who might be developing a problem, have low level problems.
Yes, it is preventative.
Yeah, it's preventative. But the problem is that if you are someone who is on the trajectory to developing schizophrenia, unfortunately, having someone to help you with your anxiety when you're younger isn't going to stop you from developing schizophrenia. You need more than that. And what we need to accept is this, that all mental illnesses will manifest in some way with a bit of anxiety. Whether you've got depression, anxiety, post-traumatic stress disorder, chronic psychosis, bipolar illness, type of schizophrenia, there's always some anxiety that goes on. You can go and talk to someone for a little bit and they will help you feel better. That 50 minutes to an hour will help you feel better. But what you need is someone to recognise that this isn't just ordinary anxiety, there's something else going on here. And it means then, because what happens is you feel better for that hour, then you go away and you think, I'm still hearing the voices, it's not so great, and you come back the next week, you talk to the person for an hour, they make you feel better, then you go, and so on and so on. It goes on for years. But you still have the problem. And I say this as someone who, unfortunately, meets people after the fact. I don't drag people off the street, I meet people in prison. I meet people who are 19, who were at school until they were 16, doing brilliantly, 10 A stars, and then, for some reason, lower six, everything falls away. And you sort of think, what's going on? And what's happened is that people are a bit anxious. It's not just anxiety, it's much more than that. And actually, you look back at their history and you think, obviously you were going to have something really serious going on here. If only I'd met you when you were 3 or 4. So actually, you do need centres like Jasmine's. But those centres need to have people who can recognise what's going on and recognise the people who are going to be the ones who are going to have the severe problems later on so that they can help divert it. We also need to have parenting interventions, absolutely crucial. Yeah. Someone talked about the nanny state yesterday, and that what we need to do is just impose, lots of kind of bans on people. And I was thinking, no, what we need to do is support parents so that they understand what is going on, and support parents so they recognise where the mental health problems might be and recognise how to manage them. If you meet someone who's, you can meet someone who's like 2 or 3 years of age, and I can tell you that this child might actually have social processing difficulties, they might have neurodiversity, which is fine, except for the fact that when you are older, 1 in 2 people will have a mental health problem. Yeah. What we would really like to see is early intervention, very early intervention, and particularly parenting intervention. That will make all the difference. I would recommend that when we put out our early years report next week, you look at it and you read it and you go through those recommendations. I'm really hopeful that any government, and especially I'm looking at Abena now, but any government will take into account those parenting interventions. because it will make all the difference. Thank you.
Thanks, Lade. And finally, I'm going to hand over to Abena Oppong-Asare, who is Shadow Minister for Women's Health and Mental Health, to explain how it will be better under a Labour government.
I want to say thank you for having me. It's good to be on a panel with people that have been working on this for some time. I'm a few weeks into my role, but this is something that I'm personally passionate about. I've been doing this work behind the scenes as a constituency MP, and also before that as an activist. So Dawn's already talked about the statistics relating to black maternal health. We know that's absolutely shocking, and particularly also furthermore when you see black men and black individuals are more likely to be sectioned. And Lade's mentioned a bit about discrimination, particularly in this sector. And this is something that I picked up particularly when I was a constituency MP within my first year of Parliament, where I did a report based on my constituency, Leaving No One Behind, where I spoke to a number of health professionals who also talked about their experiences, particularly during COVID, where they were being made to work in COVID wards more in comparison to their white counterparts, and being pressured in those circumstances. I raised a number of questions in Parliament, and it was reported that I was the new MP that asked the most questions in relation to health. I think I was a particular pain to Matt Hancock at the time, but I was just frustrated that there wasn't much data in Parliament to look at this, address this issue, or recognise that this was a problem. We all know that these inequalities existed before COVID, but it's exacerbated even more since COVID. And I do know that there are organisations, health professionals, already got that data at work, but as Lade says, there needs to be more of a willpower in terms of the government doing this. And so I will talk about what we will do, what our ambition is so far as a Labour Party. I also wanted to talk about some of the work that our organisations have done. So the Black Voices, the Voice newspaper, in partnership with Cambridge, just done their biggest research so far, where they surveyed about 10,000 black individuals. So I hosted their event in Parliament a few weeks ago, and the statistics from that were alarming, but to me they weren't surprising. But I think it's really important that they've done this piece of report. I'm going to be sharing this with parliamentary colleagues, and we're looking at doing some further events in Parliament to create awareness, so we can get my parliamentary colleagues also raising this with the government. And I've also advised them to also raise it directly with the government minister. So the data that came out from the respondents was that fewer than 1 in 6 respondents felt they were fairly treated in the healthcare system. And they said a lot of the responses to that was that they felt it was a hostile environment. 87% of respondents reported they expected to receive substandard healthcare. 81% felt mental health support for black people were inadequate. Now, I'm pretty sure you already see this already. We already know this anecdotally. I know this from the experiences of my friends and my family, but I think to see that data written down is particularly powerful. As a party, we have been having conversations about what we could do differently. The current situation with the government is, I know there's frustration from conversations that I've spoken, particularly when it comes to mental health, that there is being a delay in terms of reforming this, the Act, and the government looking at getting this installed. And I know that a number of health professionals and organisations have been doing a lot of work to try and get this put forward. Labour supports it in principle, but we also want to go that step further, where we have said, and this has really been done from the work of Annalise Dodds, so I can't claim the credit for that, where the Race Equality Act that we would look to implement when we're in government we'll also look at how, through all departments, as well as health, address the inequalities that exist. Dawn also mentioned about the black maternal health. We've made a commitment as a party to look at how we can address black maternity health in terms of making sure that we can reduce the outcomes in terms of death. Keir Starmer, along with Wes Streeton, so Wes is our Shadow Health Secretary, set out a few months ago one of our health missions, which Jasmine has talked about, which is key, which is health for everyone, regardless of your class, ethnicity, gender and other social factor, because we do know that there is huge disparities, particularly when it comes to race as well, and also regional inequalities, as members of the panel have talked about, depending on where you are, depending on your wealth, depending on how much you earn. That's a key factor as well. And also, Lade, you've talked about early interventions, particularly starting from very much early on. This is something that we do support in terms of prevention, but also I'm taking on board what you said about parenting interventions. So that is something that I'll be taking back. I am new to my role, but I think that's something that I think is an important thing that you raise. So I'm also looking forward to the report that you'll be doing next week, hopefully not next year, on early years reports. But things that I think is also important is making sure that whatever we do as a party, we do work in partnership, particularly with organisations, charities and other stakeholders. But I also think it's really important we listen to people about their experiences, because I don't want us creating policies that aren't going to benefit people's lives. So we need to make sure those that are at the top table advising us work in that sector, but are also from diverse backgrounds. That is something that is particularly important to me, because I do know that does affect the outcomes in terms of how people benefit from the health system. And let's be honest, if you look in, particularly in Parliament, it's not particularly diverse, which is why I think we see a lot of things in terms of health disparities that exist. And also looking at proper monitoring as well, because as I've mentioned, there is the data out there, but it's being done individually and it's not being centralised, which makes it very difficult for us to get a grip of the situation, and so proper monitoring needs to be done. We've also talked about as a party about NHS workforce training programmes, and that needs to include awareness, particularly the experiences, and making sure that there is diversity and recognising that people have better experiences when they're going to see a health professional. I know from my friends, I know from the experiences I've gone through that particularly when you've gone to see a health professional, sometimes you've had to go over and over again before you were taken seriously and properly diagnosed. And I think that's really links into the point where you talked about discrimination. We have to acknowledge that racism and discrimination does exist, and that's something that really needs to be kind of looked into. Other things as well is also about cultural differences and barriers that can also affect people's outcomes. So to give you an example, is I've done work with Sister Space, who have been doing campaigning for Valerie's Law. So for those of you that don't know, Valerie Ford was a black woman that was murdered by her ex-partner, her and her young child. She'd gone to the police to report her experiences and she wasn't taken seriously. So what you tend to find is, particularly if you've got a darker complexion, you don't always see the bruises, isn't always taken seriously. So it's about actually looking at how various people, stakeholders such as the police, health professionals, recognise the cultural barriers that exist, and also do have the training to look at making sure that they provide the adequate support. I'm just using that as an example in terms of how that could be done. particularly when looking at the health side. Other things I also wanted to touch upon is, I know that local authorities like Southwark Council are doing a lot of work, particularly to address this. And as a Labour Party, we've said we want to give more devolved powers, particularly to areas, and that would include local authorities, because as we do know, each area has different issues in terms of demands, and if it's always centralised in Westminster, you're going to find that there are going to be people left behind. So that is something that the Labour Party has been talking about. So I hope that gives you a snapshot of what we would do as a party, and also hope you recognise that this is something that I'm personally invested in. I think we're in a better position in addressing these issues than we have been in previous years, and the wraparound support is important, particularly when looking at health, looking at racial health inequalities, not looking at it in isolation, particularly whereas you mentioned about people's economic backgrounds, those are their housing situations, because it exacerbates their mental health, and so these are things that we know as a party what we need to do. I'm really keen to hear from a number of you about things that you think that we should be doing as a party, because I want to work in collaboration with you. So that's what it is. Thanks.
Well, it's a nice segue to Q&A, so we've got time for a couple of questions. Who'd like to jump in? Yeah, both of you here.
Hi, yeah, I'm from the First 1001 Days movement, so we're a coalition of 200 charities, children's charities and professional organisations who care very much about what happens in the first couple of years, because it makes such a difference to long-term outcomes. I'm also from Lambeth, but I'm not going to get into Lambeth, Southwark, so we've got some very similar challenges in Lambeth, and we've got an excellent parent-infant relationship service in Lambeth that is providing really great support. But the challenge is that's quite a rarity across the country. There are only around 45 services or teams like that, and so we're very excited by the prospect of Labour looking at a long mental health strategy, then a long-term mental health strategy, and very keen that early years in prevention feature really strongly in that. So really looking forward to what's coming next. Do you think it would take 10 years to turn things around? And should our ambition be, as Councillor Jasmine said, hopefully the ambition will be that everyone should have access, even if it does take several years to get there, because we know we're a long way off.
Thank you, and a huge thank you to everyone here on the table for what you're doing, because I think we found our voice, and we need to carry on pushing. I think I've got a couple of things to say. A lot of things we're talking about with regards to the precursor to mental health is a wider determinants of health.
Yeah.
So I'm going to talk about housing. We've got unemployment. In Southwark, I found out actually 26% of our residents are food insecure, compared to 9% of the white population. That is a big precursor to mental health that we found as well. And so the life course approach is imperative. So we have to look at all aspects of our life course and how we close that inequalities gap in the various places. But approach will fail if it's not culturally appropriate. And what do I mean? I mean that being able to, as you say, Lade, picking out exactly what is uncommon, what looks different, what do we need to pick up and support. And so to Agnes' a question about what can we do more, the VCS are going to be very important in this. The voluntary sector, who are underground, who are culturally diverse, who understand the various cultures, understand who to go, how to get the support. And that's why places like the Nest is really popular. Why? Because the Nest is culturally appropriate and it's in the community. So we need to be able to work with the VCS to be able to support us in this as well. Abena, you also mentioned data. Data is not as vast as we think they are. We're doing a commission in Southwark on maternal inequalities, and what we found actually is that we can't get data drilled down to borough level to see the inequalities level. How many of our black women are dying in Southwark? We can't find that data. So in as much as we have loads of data, it's not really drilled down, and the kind of the specification of kind of the race it's not there. So we need to really work on data, and I think I'll just leave it there. So the VCS is important, how we find them, how we get them involved, and also data as well. So thank you for all the points you made.
And were there any questions? Yeah, gentleman there.
Yeah, hi. I'm Tom Harrison from the Wellcome Trust. Wellcome's one of the largest non-governmental funders of mental health science. So I'm just really interested to get the panels to you on kind of the science role within this, and what potentially a new government, a Labour government, might approach investment in mental health science. We're seeing a potential new breakthrough treatment in schizophrenia, for example, with CAR-XT, and there are lots of other breakthroughs that we might be on that we call the tipping point. And so I'm just wondering about that role in terms of improving the interventions that we have, not just the way that we roll out services and provide for people. So your views on that would be interesting.
We've got about 5 minutes left, so can we just a minute each? Yes.
So very quickly, parenting, absolutely. The VCS, so I don't know if you know about this, but there's a patient care race policy framework that I was involved in developing, and Dawn was involved in developing, came from the Mental Health Act Review, and we hope the reforms are going to go through. The idea of that is that there is a tripartite collaboration between statutory services, the community, voluntary services and so on, and you work together in a local, place-based way to develop what's needed for that service. So actually that is happening, it is happening. The other thing that people need to know is that in places like South London, many of the staff who work in our units are actually from the same places that the patients are from. And that's really important. I think there's often this idea that they're very different, but as everyone will know, huge numbers of people in the NHS, there's a much higher proportion of people from minoritized ethnic backgrounds in the NHS than not in the NHS. And so the good news is that there are changes. There's more to be done, but it is improving. For research, this is absolutely key. You look at HIV. When I was a medical student, HIV was a little paragraph in the, I'm giving my age away now, but it was a little paragraph in the medical books. And then it became this killer disease. People wouldn't touch light bulbs and so on. They wouldn't touch the door with someone else if they thought someone else might have HIV and so on. And then, money was thrown at it, good research was done, and now it's just not really a problem. If you're lucky enough to live in a Western country anyway. So the thing is this, that actually the Wellcome Trust is really, really important in this. Wellcome Trust and other areas like it. But we know that the problem is that the research that's done, the funders decide on the research, and they decide on the research because it's often based on who do we know is going to deliver. And it's very difficult for them to give a punt to someone who might be doing stuff a little bit differently. And that's what's going to have to happen, actually. Because the ideas that are generated, whether researchers think, and I know this from doing a lot of research myself, researchers often think that they're eliminating all the bias. But the reality is that what we don't do is think about the world in which we live, which unfortunately has structural biases inbuilt into it. We really do need very concerted research, and particularly in mental health care. In mental health care, sorry about this, but it's a real bugbear of mine. As it happens, the treatments are holistic, actually. It gets on my nerves when people say medication or psychology. It's like, it shouldn't be like, it's everything. But we do know that the drugs, particularly for illnesses like psychosis, the antipsychotic drugs, they work, but they've got horrendous side effects. If it was cardiology and you said, well, this drug really, really works, or cancer, it works, but it's got horrible side effects, yeah, let's just get rid of it. You don't do that. You say, let's refine it and make it better so it doesn't have side effects. So I would say over to you, please, 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 fund mental health research. We need it. We need good research. We need the government to force you to do it so that we can have better treatments, because we know the treatments work, but they need to be refined.
Abena?
Yes. So your question about should it take 10 years? Well, we have a plan in place, a long-term plan, an urgent plan, but we haven't been in government for 13 years, so we do have a mountain to climb. So it is going to take us a while to get things back in order, but we are already trying to do the work, particularly as an opposition, to make recommendations on how the government could do things very differently. But when the next election comes in, we do not know what we're going to inherit. So I cannot tell you right now how long the plan is going to be, because I don't want to, give you something that isn't realistically right. but I'm sure you've seen our health missions in terms of what we want to set. Evelyn, you talked about the not being able to get the borough data. You know, I wasn't able to get the data in Parliament, hence my many parliamentary questions. And I do agree with you that you should have access to that data, which I think links into part of our plan in terms of making sure we look at the latest technology, so that information and data could be shared very quickly. I do also recognise Dawn's concerns, which I also have concerns about certain ethnic minority groups not having access to data, which I think is something that really needs to be looked into, because there are significant barriers, particularly if English isn't your first language, in terms of being able to access certain things. The data shows that not a huge amount of people, particularly from those backgrounds, go on Zoom to do their appointments. So more work needs to be done if we're going to move towards that kind of model in terms of looking at how we can access their data or move in with technology, which links into your question about science and innovation and technology. We are very open to looking at how science could be done. It's not an aspect of work that I'm working on, and I need to get up to speed on what we are doing on that, so I'm not going to just tell you what it is, because I'm still very new to my role. But I do know that's something that we know. If we want to reform the NHS, to transform it, we do need to look at the latest sciences, because there's treatment out there that can help diagnose things earlier, so people can get treated quickly. And as you said earlier, that would make more economic sense, to be honest. So I think those were the 3 questions.
Great.
Yeah.
Perfect, thanks. Jasmine, do you want to come in?
Yeah, that'd be great, thank you. Research, of course, important. I think you've got ringing endorsements from the people who matter on the panel, good. But access is crucial. Look, I mean, I did describe a model of prevention, but there are no bones about it, right? We do need clinicians. Of course, clinicians are important, but, the children and young people that gave me evidence, that gave evidence to the NHS who didn't, who didn't think prevention was needed, not on the panel, but, on my health and wellbeing board. Well, they didn't think it wasn't needed, but they didn't think, opening a centre would help. The reality is, that young people gave testimonies that night, and they told the Health and Wellbeing Board that they had to self-harm in order to compete, to get appointments. And then when they did get appointments to see clinicians, if they didn't turn up, to subsequent appointments, then they were back to the end of the queue. I mean, it's just, in Southwark, we are very forward, and we're trying to get in front of this. But even then, we have children who are 110th on the waiting list. Do you know what I mean? And how do you then, get them to the front? For children in care, you can get instant access. So, we've managed to do that, but, we're not managing to do it for everyone, and we need to. So really, I would say, in answer to your question, which I think is the key question here, we haven't got 10 years to wait, because we cannot fail our children. And I think, thank goodness that we've got, Abena, fighting our corner. And we know that you're not going to let us down.
Yeah, sure. So as somebody who's doing research in the space, I can tell you how challenging it is. And my research, when I first started trying to get some funding for it, it was described as being too niche to be funded at a national level. So that is a real issue, is that the people who are reviewing those grant applications don't see why this matters. And so having different ways of doing research and different ways of evaluating it, bringing in service users and their family is not something, we talk about co-production, but actually for a lot of people that just means we design it and we ask if it's okay, and then that's co-production, rather than genuinely getting together and doing it. So we need to fix that. I do think that we talked about the data. In mental health services, in some parts of one of the organisations that I work with, there's 20% missing data, and even the data that's there around ethnicity is often inaccurate. So somebody looks like you and go, "Oh, you're Caribbean." Never asked you. what your background is, so the information isn't accurate. So there's a whole piece of work which, to be fair, the NHS is trying to do something about, but why they're trying now, when we've got an Equality Act that requires people, who, in terms of the way that's supposed to be worked out, to actually do this work, and this just takes them back to the point I made before about commissioning. If commissioners were told organisations, they would have to provide that evidence data. They would have to then talk to it, not just in terms of who's accessing their services, but the experiences and the outcomes, and we would have that information. And if we didn't have it, they'd say, go and get it, because what you're commissioning for, if you don't know how many people you're commissioning services for, how are you doing that? So, and I think, and that takes me on to the workforce issue. I think it's absolutely scandalous that you can graduate from a health and care profession in 2023 having done no work around diversity and difference. That's not just about ethnicity. There are some exceptions and there are some programs. I know the Royal College is doing quite a lot of work about this, but they're doing it. This is not something that's embedded within the system. So you can finish your qualification, I won't name any profession, and go into work in Southwark, in central Manchester, and you don't know anything about working with people with diverse backgrounds, not just in terms of ethnicity, but social class, and people with different terms of sexual orientation. There's a whole lot of stuff that we're not doing, that we should be doing better. And it's coming out of our taxes. We're paying to train people. They should be trained to be able to work with us, whatever we look like, wherever we're from.
Yeah.
Right. I think we're about to be turfed out.
I think so.
But I think that's just testament to how full a discussion we've had. So I'll go back to say thank you to the panellists for their insights. Thank you for all of you to be here. And just a quick word of advertisement from our partner Politics Manchester. They're publishing a collection of articles called Open Minds, which comes out today, with articles on inequality, loneliness, breakthrough therapies and treatments, and that is available from the Politics Manchester website, so do have a look at that.